just says, Anna, I'll let you know when I start recording. I should be good. Well, she can hear us. How can she record us?
I do not.
Okay, we'll start now. Right.
Okay.
Right. We're starting. So, hello everyone. Sorry about all the technical hitches. We're a little bit late starting, but welcome to the Academy for Eating Disorders webinar entitled Getting It Right, Ethical Considerations in the Treatment of Eating Disorders with Jacinta Tan, PhD. I'm Anne Stewart and I'm your moderator today. If you've got any questions or concerns about the webinar, please feel free to reach out directly to Dawn, who's Deputy Executive Director at AED Headquarters, via email, and that's dgannon, Dawn Gannon, dgannon at aedweb.org. You can also reach her by dialing 703 234 4125 in the US and by adding a +1 outside the US. I'll just repeat that number, 703 234 4125. So just a couple of housekeeping items before we get started. All participants are muted with the exception of Jacinta and myself. So when you send messages, actually it's only us that sees them. The webinar is scheduled for 90 minutes and is being recorded. It's going to be posted on the AED website quite shortly after for AED members to download at their convenience, and that can be 24 hours a day, 7 days a week, anytime you feel free. So in just a few minutes, Jacinta's going to begin her presentation, after which she's going to answer questions from the audience. But please feel free to submit your questions to me during the presentation using the chat text. It's the box on the bottom right-hand side of your screen, and I'm going to read them out to her when the question portion of the webinar begins. So, do we need to just check your volume again?
Okay.
Jacinta, do you want to say something? And then please send me a message if you can either hear clearly or you can't hear.
Okay.
So,
Thank you very much, and I apologize if you can hear my phone going off. But hi, I'm Jacinta, and we're just checking the volume right now before we get started.
So can somebody just reply to say that the volume's okay?
Or if it's too loud,
Yeah.
too soft.
Oh, wait a minute. Oh, yes, somebody is typing, so presumably somebody can hear. It's good, but be aware of fading away from the microphone. Thanks very much. That's really helpful. We'll try and stick quite close to the microphone.
Okay,
that's really helpful.
Fantastic.
So let's begin by introducing Jacinta. So for those who don't know her, Jacinta Tan is a research psychiatrist and medical ethicist and a clinical associate professor of psychiatry at the Swansea University Medical School. She's also an honorary consultant psychiatrist in the adult Tier 3 specialist eating disorder team of the ABM University Health Board in Wales, UK. And she's actually previously worked as a child psychiatrist as well, so she has experience across the age span. She's basically a multidisciplinary academic with a background in philosophy and psychology, child health and sociology, and she spent many years researching mental capacity in anorexia nervosa at the University of Oxford. So, without further ado, Jacinta, I'm going to hand over to you to get started.
Thank you very much. Right. Well, ethics, I'm even pleased that anyone's decided they want to listen to ethics. So Uh, but what I want to say is why it is important. It's one of those things that permeates clinical practice rather than actually being very interesting as a standalone topic. And that's because the law in itself prioritizes patient autonomy and patient rights. And eating disorders can have very serious consequences, as we all know, on all fronts. Yet at the same time, many people do not acknowledge that they have the disorder, or they are at best very ambivalent about treatment. Some patients with eating disorders are also ashamed or reluctant to seek help, and many others resist treatment or they often self sabotage. So, on the one hand, respect of autonomy is a very important aspect of the therapeutic relationship. But on the other hand, we also need to find a way of helping people to accept treatment, and sometimes that needs compulsion. So, this is really an issue for all eating disorder professionals in our everyday work, and also for the family members and loved ones who are trying to help patients. So, really, what we need as part of our standard clinical skills is the ability to assess, to think about, and manage treatment refusal or failure to engage, and also to think about all the complex legal and ethical issues that can arise as part of treating eating disorders. So, just going through the law, first disclaimer I am not a lawyer. Second disclaimer, please adapt everything to your particular legal context. I am very, very aware that I come from a particular country with particular laws. You may not come from the same country. And I really, really do not suggest that you break the law wherever you are. And what I'm going to do in this talk, I will have to refer to the law simply because it's so intertwined with ethics, but at the same time, they're quite distinct. And what I'm more interested in is the general ethical principles that underpin the laws. And rather than trying to critique or talk about the laws themselves, which vary according to where you are. So, really, as far as I'm concerned, it's important to understand and apply the ethical principles, not just follow the letter of the law. And actually, you'll find when you examine different laws in different countries that actually the emphasis in the laws can vary according to culture, history, and society. So, if we just deal with the law very quickly so that we can get it out of the way and move on to the ethics, which is the main part of this talk. Basically, when you look at the law, there are some very broad international legal principles, although the details often vary. There are various principles like, number one, all people have the right to good health care. Number two, we tend to say that it's important to respect patient autonomy. That is, we respect patient choice, especially when it's concerning their own health and their own bodies and minds. Number three, we expect that people give proper informed consent. In other words, health professionals need to properly and appropriately inform patients of choices and consequences.
Jacinta, we need it a little bit louder.
Okay,
said,
sorry about that. Yeah. For instance, we need to properly inform people about side effects, complications, but also consequences if they refuse to have treatment. A fourth principle is that legal minors and those who are incapacitated or not competent to make decisions of any age, they often require their best interest to be considered if we need to make decisions on their behalves. A fifth legal principle is that if legal compulsion or proxy decision making is needed, we need very good reasons for what we do and what we decide to do, which appeal to the principles of best interest and the welfare of the patient. And also, we need to be trying to choose the least restrictive option. And finally, even if you're making decisions by proxy, meaning you're making them on behalf of someone else, you need to try to obtain assent, which is the agreement, which is not actual fully informed consent. So those are the principles in the law. And what I spent many years doing, together with Anne actually, was researching how eating disorders could affect decision making, and particularly in anorexia nervosa from the patient perspective. And I think that's quite informative. I am aware that, we need to generalize some of our conclusions to other eating disorders, and they may or may not apply so well, but I'll deal with that later. So in the research I did, we interviewed 29 patients, analyzed the transcripts, and explored various very wide-ranging questions, like how do people with anorexia nervosa make treatment decisions? How does anorexia nervosa influence decision-making? Are they competent to make decisions? And how do they view treatment, including compulsory treatment? So we developed this research over many years and conducted it over many years. And we interviewed some of their parents. And with a further 5 patients, I did longitudinal interviews following them up over 5 years. And my method was, rather than have a very closed topic guide, I actually tended to have very long exploratory interviews up to 3 hours. So moving on to sort of thinking about what the results showed us, there is this sort of standard conceptualization of, sorry about the spelling, of decisional capacity, where it's very black and white, quite literally. You either think that a person possesses the capacity to make decisions, sometimes it's called competence, depending on where you live, that person then is fully able to make their decisions. If so, the decisions must be made by themselves if they're adult, and they are fully autonomous. But on the other hand, if they lack capacity, they're totally unable to make decisions. Decisions must be made by other people, and they're totally lacking autonomy. And that's unfortunately sometimes the black and white way that some people view capacity. But actually, this decision-making capacity is a little bit more nuanced than that. It's decision specific. It's also time and context specific. So if you're trying to say someone lacks capacity, it always has to be about what decision, in what situation. And the default, if you're an adult, is that you possess capacity unless found otherwise for a specific decision. The general legal criteria varies internationally, but largely it covers these kinds of bases: the ability to understand the relevant treatment information, the ability to apply the information to yourself, the ability to remember, to weigh up and process the information to arrive at a decision, and the ability to express a choice. Now, the thing about eating disorders is usually number 1 and number 4 are not a problem. What we actually find from the research is that there's this wide gray area that sort of falls in between the total capacity and total incapacity. And this gray territory is often inhabited by people with anorexia nervosa. And in it, anorexia nervosa exerts a very strong influence on how decisions are made. And people with anorexia nervosa may need quite a lot of support to make decisions, and their autonomy may be variably impaired regarding eating disorder treatment. Interestingly, it's not usually affected about all other kinds of decisions. So what we found were 3 key themes related to process of decision making in anorexia nervosa: influences on decision making, relationships, and attitudes towards compulsory treatment. So if we go to influences on decision making first, there's several things. Everyone has a different style, whether you prefer to make decisions in an individual or as a group. They may have levels of anxiety. I'm sorry about these being rather different. There can be all sorts of difficulties, like applying the facts to yourself, difficulties in acting on your wishes, different levels at which you might or might not be able to make decisions. By that, I mean, for example, on a global level, you may not be able to say, I want treatment, but you might still be quite able to just say, I will eat that plate of food. On the other hand, it can be the reverse, that someone might not be able to say, I want treatment, but then when you put the plate of food in front, what did I say? reverse, sorry. But you might be able to say, I do want treatment, but yet when you're given a plate of food, you might not be able to eat it. Sorry about that. So you can have all sorts of variations that people might be able to do both, not be able to do both, or be able to do one or not the other. And obviously, we do have things like impaired thinking and concentration. But what we found also is that value systems can be affected in anorexia nervosa. So can identity. And people can have great difficulty applying the facts to themselves. Usually they understand the facts very well, but they have difficulty seeing that it's really relevant to them in a way that's actually meaningful. And they finally could have difficulties on acting on what their wishes are. So let's take identity, for example. Here's a quote from the research. Quite often, people with anorexia, they don't say, I have anorexia. They say, I am anorexic. And I think that's kind of, it explains it really, that it shows that people become anorexic. And then they start saying, I am anorexic. And it's this thing, it becomes who you are, it defines who you are, as opposed to just an illness you have. And that obviously is quite relevant to how you make decisions about whether you want to get rid of the anorexia. So someone else said, I've had it so long, I think it's more a part of me than something that's just sprung on me. I look at it as the anorexia as me, like it's what I did, that's what I'm all about. If I did eat normally, I don't think I'd be the same person. So there are lots of implications then to how you make the decision and whether you can choose to recover. Some people said to me, if I could wave a magic wand and get rid of anorexia nervosa, wouldn't you like that? And I was like, well, no, because it's like, it's safe. It's what you know. And although it's killing you, it's what you know. That's my identity, having anorexia. And I was too scared because that was who I was, because I'd be losing me. Who would I be if I didn't, if I wasn't that? I was too scared to make that decision to give it up. Here's another difficulty in expressing what their wishes and desires are. So I asked, what are the things that professionals who treat anorexia nervosa should understand or do differently? And this person said, they should understand that when people say, I don't want treatment, perhaps they actually do. Like sometimes even consciously in their minds, the patient is actually thinking, I do. It's not just necessarily a subconscious feeling that they do. It can also be a conscious feeling that they do. They're just not expressing it. And of course, that leads you into all sorts of ethical tangles about how you determine what the patient actually wants. And some people can say what they want, but they can't act on their decision. So I said, I did a lot of this kind of posing of hypothetical questions. And I said, if you wanted to eat more than you do, could you actually do it? And she said, well, I always thought that I could. Like before I tried it, I thought all the time that I could easily eat more and stop this if I wanted. But when I came to try to do that, then I couldn't. So we move on to relationships. And what we found is that relationships are really, really important in determining whether people find themselves able to make decisions around treatment and recovery. So, for example, it was really important to be listened to be understood and respected. People needed to be able to trust their professionals first. And pace of treatment needed negotiation. And finally, and really quite interestingly, free choice was often less important than how a person is treated. So this is someone who said, I mean, trust was definitely the key issue with me, because if you don't trust your doctors or if you don't trust your parents to be doing what they think is best, then you're not going to do it. So really, I think sometimes when we look at the ethics of decision making, it's always about the patient and what they can do and what their decision is. But actually, people are saying it's actually more important that you trust the people. And often you might go against your own better judgment. And if you trust everyone around you, that maybe they know better than you do. And sometimes restriction of choice is seen as supportive. So someone said, you need help, you need treatment, you need to come to a place where you get extra support, extra external help. You need to hand over the controls because you're not in control anymore. It deludes you in thinking you are in control, but that's where you have to stand back, or someone else has to stand back for you and say, look, you are not in control, it is completely controlling you. And what I found is that there was no difference between the degree of lack of choice that people perceived as support and as coercion. It all depended on how they perceived um, the restriction of choice. And so that was really quite important. So when we looked at compulsory treatment, what we found is that, as I said, compulsion was very much a perception of other people's behavior rather than a specific degree of restriction of choice. And people all said we should use it to prevent death. There were some people who made arguments for early compulsion, so as to save suffering and stop people from sliding down before we then rush in and scoop them up. Some people said they actually desired to be compelled because they couldn't fight against the anorexia nervosa themselves, but actually wanted somebody else to be compelling them to have treatment. And I have a feeling that's quite familiar to a lot of professionals. And finally, there was often a great appreciation of people taking a tough stance, but in hindsight. So someone said, no, you need help, you need treatment, you need to come to a place where you can get extra support, extra external help. You need to hand over the controls because you're not in control anymore. And someone else said, I think other people should be made to have treatment. And that, by which we mean, brought in under the law, because you do get to the point where you don't know what's right for me. I know last year when I was ill, there was no way I would have let anybody do anything to treat me. Like for my own choice, I would have just carried on losing weight. I know I would have done until I didn't live anymore. But now I hate to think that just because I said no, I would have been left. So what are the clinical implications of the results? Well, what we would say is that anorexia nervosa can impair decision making. And I don't think it's necessarily even linearly related to how much weight you have lost. Often decision making is impaired quite early on, where people are in the grip of the disorder and sliding downwards. We need to take account of different styles and different levels of decision making, if you remember the global versus the day-to-day decision making. But also there are many different styles of decision making that's quite important to think about. So people from certain cultures, which may be societal cultures, but also subcultures, family cultures, may actually need to make decisions with other people. But certain other people may need to make decisions on their own before they can stick. As I said before, there is a huge importance of trust and respect. And also, patients told us that it's very hard to choose to get better, and actually that restrictions can be welcomed if trust exists. So the overarching thing we would say is that the dilemmas can actually be made overt, that we can actually say what these are, and they can promote collaboration. So again, it's not black and white. It is about working together with patients. Okay, I'm aware all that research was about anorexia nervosa, and that is, not all that we see in eating disorders. Now, I would say that anorexia nervosa and its variants are the most problematic because of ego syntonicity, that it's... a little bit. Okay, sorry. Because people feel very identified with it. And it's also particularly problematic because patients often want to keep it, at least some of their disorder. So anorexia nervosa is often seen as a talent to lose weight at will, which a lot of women in society would like to have that. And there's less of a talent or a gain associated with having something like bulimia nervosa or binge eating disorder. And the third reason why anorexia nervosa is particularly problematic is because you can get some lack of acknowledgement of any illness that can occur. And this is often promoted by things like pro-ana websites and other sort of sometimes inadvertently by anti-obesity drives that actually make people think it's wonderful to be really, really thin. But I would say that all eating disorders can have valued aspects. For instance, eating disorders often give people a sense of control, or are ways in which people manage themselves. Eating disorders can have the function of being comfort and self-soothing. They are often a focus as a distraction from other aspects of life. And if we're honest, they are often a means of managing others or eliciting cares, and it can be tied up with relational issues. A really big thing is that shame, of course, can prevent people from seeking help or acknowledging problems. And I think also there's often a sense of not deserving help or of the illness being self-inflicted. And actually, I think there are, ethically speaking, quite a lot of parallels with addictions. That often you find the same inability to make changes and need for help to do so. Yet, at the same time, you often need the patient to be able, at the end, to make decisions to accept the help themselves. So it's this sort of paradox that you find in eating disorders that's quite similar to addictions. And this is not just me making those connections, because this is something that the research participants actually often talk about. Okay, let's move on to something else and talk about consent. I want to introduce a few different sort of ideas and concepts for you to think about. Consent, we all think we know what consent is, but in fact, it's not as simple as all that. So for instance, right at the top, you might have the sort of gold standard, which is verbally expressed individual consent. Yes, doctor, I definitely want treatment. And we say, hooray, and it's all great. You might have a verbally expressed group consent. I talked with my parents and we made a family decision, we want treatment. You might get proxy consent and delegation. Let my parents decide, I really can't make that choice. Now, I have to say, this happens for adults as well. It happens for all of us. We may feel very vulnerable when we're very ill, and we might feel overwhelmed about making decisions. And I think it's actually perfectly legitimate to say you give someone else the permission to make the choice on your behalf. There's also tacit consent. Well, I came when you sent the appointment, didn't I? So what are you saying? I don't want treatment. I came. So that's all quite tacit. You get verbal ambivalence. No, I don't really want this, but I'll go along with it. And of course, you've got, on the other extreme, verbal refusal. No, I don't want this. I refuse. Okay. So it's a bit like the gray area. It's not as simple. So if you kind of more or less plot that on one side, what I want to point out is, and this is a real issue in in eating disorders, is behavioral consent. What do I mean by that? For instance, you may have someone with clear individual behavioral engagement and compliance. So this person does what we suggest that they do. They come to all their appointments. They really seem engaged. You can have a clear family behavioral engagement compliance. Patient may be ambivalent, but the whole family's always coming. Everything we suggest gets done. Great. You can get tacit individual behavioral engagement or compliance, tacit family behavioral engagement or compliance, clear individual behavioral refusal or resistance, and obviously clear family behavioral resistance or refusal. And obviously there can be some combinations. And the thing I want to point out is that you could have one thing in one column combined with something else from a different column. They may not all match. So you can get all sorts of combinations. That's the thing I want to point out. So it's actually sometimes not so easy to determine whether somebody's actually consenting to treatment. So bear that in mind, because I'm going to move on to the next point, leverage. Okay, what's leverage? It's basically the use of informal pressure or restriction of choice. And leverage is a term that is used in studies with other mental health patients, not with eating disorders, where American clinicians use the control of health benefit claims in order to achieve compliance. So it was actually put as something that was very unethical. That clinicians were saying, well, if you don't do what I say and take your medications, I will not sign you up. But actually, when you think about it, leverage describes a range of everyday limits to totally free choice. No one has totally free choice. So, for instance, we expect children to go to school. We even guilt people into helping us. Hey, I did this last time. Come on, do this for me. And of course, we do it in eating disorder treatment all the time. For example, well, if you won't accept the treatment we offer, I might have to consider committing you to hospital or using a compulsory treatment order. Well, if you can't eat at home, we might have to admit you. If you gain weight, oh well, then you can continue to go to school. If you don't gain weight and you or follow the treatment, I will have to write a letter to your coach that you aren't medically fit to compete. If you can't engage in treatment, we might have to discharge you. Now, all these are leverage, aren't they? So what I would say is if we put it together conceptually, at the top, the place we like to be with our patients, we have fully informed verbal or written consent with behavioral compliance. Hooray! Right at the bottom, you have stated refusal with behavioral resistance. And actually, I would suggest that what happens is you have this whole area in between where obviously if the patient's completely on board, you're happy, there's no leverage, everything's fully cooperative, fully collaborative. But actually, as you slide down the consent sort of spectrum, I guess, you will tend to see increasing degrees of leverage between the various parties. And then you reach a point, following the green arrow, where you get maximal ethically appropriate leverage. At that point, you need to stop using leverage and move on to using formal legal measures, if necessary, or else, I guess, just ease off altogether, depending on the situation. And I would suggest that leverage can be still clear and explicit, collaborative, and respectful, because if you think back at some of the quotes, people were saying, I need some leverage, or maybe I need quite a lot of leverage. This is what I want. So people will say, obviously, it's probably slightly shocking for you to hear this coming from an ethicist. Isn't leverage illegal? Isn't it unethical? Well, I would say we all experience and we all accept leverage in life. We limit children in their freedoms of choice, and especially as they're developing, we would actually say it's actually really important that parents are helping and directing their choice and exerting leverage where required. And leverage comes from all directions, from our friends, from our family. We put social pressure on people to conform to rules and expectations, for instance, in the workplace, social behavior, concepts of reciprocity. And we often accept pressures to do certain things in return for other things we want. So leverage exists everywhere. I think, again, a very black and white approach to it, saying leverage is just bad, is not very helpful. But I would say leverage may not be unethical if it's fighting against the illness rather than fighting against what the patient wants. And that then gets to the heart of authenticity, which is about whether the wishes are really of the person himself or herself. So, for instance, we do get patients who say, I want you to tell me I have to eat. If it were up to me, I couldn't. In which case, the patient is clearly saying, please, can you use leverage on me? So then I would say it's not unethical. It may not be unethical if it concurs with what the patient wants. So really, I'll give you another example. Think about all the personal coaches that you pay to come and get you out of bed and make you exercise, even though you really don't want to exercise at 6 a.m. in the morning. you're paying people to use leverage on you, to actually not give you all that much choice about staying in bed and not exercising. So I would say acceptable leverage has clear limits. So, in other contexts, we'd say excessive leverage by work superiors becomes bullying. Excessive leverage by healthcare professionals becomes coercion. So that's the bit that is really, really difficult. So I sort of came up with some ideas about when leverage might be ethically okay, but not always. If it's desired or requested by the patient, if it's in the patient's best interest or in response to their signals, um, when it's experienced by the patient as supportive and not coercive, when the patient lacks capacity and clearly needs the support and boundaries, when it's done in a gentle and kind way, when it's realistic, when it's honest about consequences, when it's within developmentally normal limits. What I mean by that is, for instance, what may be totally appropriate in a 6-year-old. You grab their hand, you stop them from rushing across the road, you follow them everywhere, you don't let them out without someone being there, is not necessarily appropriate in a 16-year-old, and definitely not appropriate in a 24-year-old. So there are developmental issues and considerations when you talk about leverage as well. And leverage, I think, is probably also experienced differently at different developmental stages. So leverage could be collaborative, and it can be explicit and agreed with patient and family. Now, leverage is definitely not okay when it's used dishonestly, autocratically, coercively, disrespectfully, or as a threat. Leverage is not okay if there's no support from family, if it denies autonomy without allowing the person appropriate participation in decision making. Obviously, it's not okay if it's illegal or unsafe. If there's absolutely no consent and clear resistance, leverage is probably not okay. And if there's no consensus in the team, then it's probably a bit dodgy to be doing it. So basically, the bottom line, I would say, is if there's no agreement and clear resistance with no support from the family, then leverage is probably not ethically justifiable. Okay, so that was quite a lot of complex stuff, but I think, that was quite general. What I want to do is move on to um, what we call C, severe and enduring eating disorders, sometimes also called severe and enduring anorexia nervosa, chronic eating disorders, and end of life. And what I'm going to do is, this is not a clinical lecture in terms of trying to unpick the concepts of these labels, although I think there's quite a lot of critique that can be done. But I just want to kind of look at some of the general issues that come up, which I think might be helpful for everybody, whether or not we see these cases. Now, there is a legal and ethical context to why we're so much consumed by thinking about these cases. There have recently, in the last few years, been 5 cases in the UK, and I know of one US case, there might be more, where the judges have been asked if the patients can be allowed to die. And these are patients with severe eating disorders for a considerable number of years. But they were often quite young too, in their 30s, most of them. We do have the UN Declaration of Human Rights, which actually says that people have various rights, and we get increasingly uncomfortable if we're constantly having to use compulsory treatment to keep people alive. We do have capacity legislation that's always talking about people making decisions for themselves and whether they can or not. And finally, just throwing in the mix, there are Dutch and Belgian cases of euthanasia for patients who have eating disorders. And they may not be the only ones in the world, but just to say, this has happened for eating disorders. So when I want to back up a little bit and pull back and look at chronic cases of eating disorders and talk about the conceptualization, because what I think is that we actually are quite loose with that idea of chronicity. And I think there's a wide range of types of people that we tend to call chronic or severe and enduring. So, for instance, if you think about it, there are people who have been severely ill for a long time. So, you're using time duration. But you can have the chaotic, very difficult patient who just simply consumes a lot of resources but never seems to go anywhere. And they're often comorbid with personality disorders, they're multi impulsive, there may be substance misuse, and so on. There are also patients who are under the radar. They're just about functioning non patient, the people we don't actually see. But these people may have had an eating disorder for 30 years. Excuse me. You might have a debilitated treatment refusing patient who is requiring repeated inpatient admission. Sorry for the cough. I have seen definitions of chronicity to include those who are ill over 7 years. Chronic cases might just be the ones we choose to call severe and enduring eating disorders. You may get a slight circularity around that. Or do we mean chronic? When we say chronic, do we mean those we don't expect to get better or fully recover? Because sometimes I find that it's not always about the duration. It's sometimes about expectations. So that was just to be a little bit challenging to everyone. And I actually think conceptually we might want to be much more careful in terms of having a multi-axial conceptualization of people we want to call chronic or severe and enduring. By which I mean, for instance, we might want to put on one axis the severity of the physical and psychological risk to life and limb. On another axis, we might want to put the severity of the eating disorder symptoms themselves. On a third axis, degree of suffering and debility, which is obviously not actually necessarily fully correlated with the first two. On the fourth axis, degree of loss of function. And so that's much more about how you function in society, in the world, in your family, and so on. And number 5, the degree of motivation to change and to return to normal. And what is normal sometimes for some people. Number 6, the level of recovery the person has, level of hope for recovery, I beg your pardon. And whose hope? Is it the patients, the families, or the teams? Number 7, what are the objectives of the treatment that's on offer? Number 8, thinking about the duration, that might be another axis of the disorder or the disability. Another axis might be the number of treatments tried and failed. And finally, the number of treatments left to try, which are, of course, usually very few because few centers have the entire range of treatments. So that's something to think about. There might be treatments out there that you don't offer, and so on. I think that would always be the case in any treatment center. So similarly, I think when you conceptualize it, it's worth thinking of it from different perspectives. So the first perspective is the index patient, so the person with the eating disorder. Do they see themselves as chronic? Do they see themselves as enduring? What about the view of significant others, the parents, spouses, children, and so on? The treatment team's perspective must not be forgotten because I think we are really quite key in how people are labeled and how they are managed. The judges, they make judgments that affect, how we behave as well. And finally, society, which has a lot to say and very strong opinions. And of course, they express themselves through the media, social media, and other such ways. So I think there are many different perspectives that we need to put together when we try to think about who is severe and enduring, who is chronic. And I'm aware I'm conflicting the two ideas, chronic and severe and enduring. And again, I haven't seen a critique that tries to pull these two apart. So I'm actually not trying to do it myself. So if we have someone we call a chronic case of eating disorder, I would say we have multiple ethical and pragmatic questions. Number one, what do we offer when patients have tried everything? Actually, what is everything? Do we mean everything we have to offer, or everything that ever was out there? Um, Number two, how do we continue when patients never seem to get better? How long can we continue to force patients who don't want our treatment to have it when it doesn't seem to make them better? Number four, when do we call a stop to active treatment when patients are going to die, but we feel we have nothing to offer to get them better? And the only thing we can do is save life. And I would add to that that sometimes it feels like it's harder and harder to save life and less quality of life when we do. Number five, what about when people make advance directives? What do we do? Number six, what about when patients want to give up and die? Number seven, what about new experimental treatments such as deep brain stimulation? And I have been involved in the deep brain stimulation trial in Oxford, and these kinds of questions have come up so much. And what about when patients ask for euthanasia? Well, I think if we try and think about it, we need to consider our goals in treatment and care. We need to actually think long and hard about our reasons for classifying someone as chronic. And in all of that, we cannot forget we need to think about team morale, cohesiveness, and function, even as we lose hope for a particular patient. I would suggest it's very useful to think about the palliative care approach. If a patient doesn't seem to be getting better, what about readjusting the goals and recovering hope for them? And hope for what? Maybe we can think about smaller goals and then moving on into end of life care. So if we try and unpick these a little bit more, our goals in treatment and care, are our goals realistic and appropriate? Are they too high or are they too low? Do we sometimes expect not enough of people? Are they agreed within the team, with the patient, with the family? And then when we talk about goals and aspirations, the first thing I thought is whose goals? And there could be a whole range of goals. You might be saying, my goal is to preserve life. Or someone else might say, my goal is to maintain some function, quality of life, and dignity. Another goal might be to keep people out of hospitals. Some might be to provide care and support. Some might be to just maintain hope. And of course, thinking about, a good life and a good death, there might be goals there. So it's worth sort of really thinking very carefully, why do we have the goals we have set? So the second item was reflecting on reasons for classifying someone as chronic. For instance, is it about a reduction in the hope of or investment in recovery? And I think there are dangers there. It might be actually realistic and kind to do it for some people, but we've got to be careful it isn't because we are managing our resources and thinking, well, you know what, I could better invest my resources into this other group of patients who will get better much quicker. And I think there are ethical issues about justice in that. Are we talking about chronic, we're calling someone chronic because we're doing a change in orientation? And that's the analogy to palliative care. Is it relevant there? Where in palliative care, you're changing your orientation without necessarily saying the person's going to die. Number three is, I already challenged in terms of number one. And of course, is there actually here a readjustment to acceptance of the eating disorder identity and lifestyle as something that's entrenched, permanent, and then becomes authentic? So it actually truly does become who you are. So we accept you as an anorexic person who's never going to ever be an unanorexic person, for example. But I'd like to give you the analogy to think about, which is the fight against cancer. So in the early stages, you fight really, really hard. You know, you find the cancer, you do aggressive treatment, you are aiming for cure. And traditionally, we would say in the later stages, we are living with cancer, you're accepting life limiting illness, you're accommodating to the disability. But the thing I want to point out about cancer, because cancer is well in advance of mental health, is nowadays we do not send advanced cancer patients home to die. We still treat them. And the other thing is, even in stage 4, you often get very aggressive treatment, and such people even do get declared cancer free. So, in cancer treatment, unlike where it was when I was a very junior doctor, where you did send people home to die, you did say, well, there's nothing else I can do for you. I do find that the approach to cancer is now different, that actually everybody gets treatment. And for the more severe cases, if they want it, they will get very aggressive treatment. And the point is, for cancer, there are new promising treatments constantly emerging. So even if, you know, at the moment, there's nothing left to treat you with, the way cancer research is going, there's always something coming up. And I know people who've had new experimental treatments and completely recovered from cancer that was supposed to kill them. So I wonder how that maps on to eating disorders, because I think we're actually not that dissimilar in some ways. And in terms of the science of the treatments, I'm not sure that eating disorders are necessarily that terminal so much as our treatments are simply not quite good enough yet. I want to move on to team morale and cohesiveness. So I think we need to actually think about influences on us as clinicians. For instance, we get compassion fatigue. We can get conflict within teams, especially with difficult cases, and splitting. We can get frustrated at the lack of reward in treating certain patients. And then, of course, there are the patients who chew us up and spit us out and sort of go through the team, wreaking damage. And sometimes we need to consider as a team, how do we maintain compassion and enthusiasm? How do we maintain hope when the patients and us don't feel any? And what do we do when we run out of new things to offer? Because you see, the thing I want to challenge is whether sometimes when we say there isn't anything else we can do, what we're meaning is, I've had enough as a clinician. And I think we owe it to our patients to always make sure that's not the reason why. But as a clinician myself, I know I frequently feel these things. So I'm not saying it as something to condemn people, but really that we need to be able to be quite open about how some of these very difficult cases make us feel. And of course, thinking about end of life, some people do die in spite of all our efforts, but the more problematic ones are the others who challenge us about whether we should be heroically saving them. And often I think there's a tension between the compulsion to save life and to respect patient refusal, as well as, how do we think about patient choice if they have a severe and disorder that's been going on a long time? How long do you deprive someone of the choices that other people can make? And what happens when we and our patients want to give up? So I actually am moving to think very much that we need to have palliative care for eating disorders, which isn't necessarily mean we think we are giving up hope on these patients. But when you look at palliative care, what they do is they bring more compassion and kindness into treatments, but they don't presuppose death as an outcome. And they all have patients who just keep going on. And I wonder whether we need to learn from them how they manage goals and expectations and so on. So I would say we need to consider futility. It's a conceptual challenge to us in eating disorder, given evolving treatments and also the great unpredictability of breakthrough on the individual cases we think would never respond do, and some others that we just keep hoping they don't. We need to consider our difficulties with degrees of certainty regarding futility. I'm very troubled by the idea that we can at present decide whether something is futile. I think in cancer, they're a great deal more advanced in knowing when there's something is futile. I'm not so sure with mental disorders whether we're quite at that state of the art yet. And I think we need to be open about that, not assume we know. I do worry about loss of hope and giving up the fight as opposed to true futility. I think a really important thing to think about is intolerable suffering and constant struggle that many of us and our patients go through. A serious ethical issue is the lack of options available, sometimes because of resources, but also because of just the state of the art not being, where it should be. And of course, a real issue to consider in terms of our approach to any particular patient is repeated or ongoing use of coercion or compulsory treatment. You'll notice I'm not telling you what to do. And I think that's because I can't tell you what to do, because I think in every individual case, it is different. So I just want to talk a little bit about the palliative care approach, and I want to stress this is for adults only. Palliative care, they refuse to say they are about terminal illness. If you speak to any palliative care physician, they call it a life-limiting illness. Actually, life is a life-limiting illness, so that's a really interesting definition. Palliative care is actually agnostic about whether you will die or not. Their emphasis is on empowerment of the patient, management of the symptoms, improving quality of life, and optimizing function. And they're perfectly happy to do that alongside ongoing treatment for say, aggressive treatment for cancer. They both are not incompatible. Palliative care never aims to end life or give up or hasten death, but they do allow the doctrine of double effect. Now, I'm aware that I'm running out of time, so I am going to go a little bit faster. This is getting quite niche. So what I want to move on to is the tools. But what I would say is mental health should work more closely with palliative care, but we need to also learn from palliative care's very gentle approach. Tools. I'm aware that I've been talking at you for a great long time, and I want to offer you some conceptual tools that might be helpful in a practical way. This is the 4 framework grid, which I came up with a very long time ago, I think, and basically what we decided was actually we need to be overt about the fact that we actually function as clinicians within many different frameworks. So there's, for instance, a legal framework that you work in, which has all sorts of legal questions which you need to think about. You then also exist societally in an ethical framework about the treatment being beneficial, is it harmful, does it respect people, does it promote autonomy, and so on. There's a resource framework, which, like it or not, we all live in. Do we have the resources? Do we have the skills? What are our constraints? And fairness to other patients, and so on. And finally, of course, not least, is the clinical framework. Are treatments effective? What's the evidence base? Is it feasible? And so on. And all these actually interact, but it might be useful when considering a very complex decision to actually assign the various factors into the different parts of the different frameworks and then look at the frameworks more objectively, really, to come to a decision. Here is a decision-making algorithm for legal minors around what to do regarding decisions about admissions. So we would suggest you should always engage them, motivate them, then move on to build trust and so on, manage anxiety, try to make joint decision making with the young person and parents, and then ideally make the decisions. But if there are difficulties in collaboration, then obviously it goes down different routes depending on whether admission is essential or not. And we do put all the different kinds of ways you could admit someone who's a legal minor. With respect to adults, it's very similar, except obviously there is less legal role for the parents. But actually, it's very, very similar, including, and ideally, we should always include the loved ones in decision making. I want to offer you this model that came out of my research, which was where I saw decision making as a spectrum. On two extreme ends, you have decisions made by others for you, and on the other end is decisions made completely by yourself. And I would suggest that if there's a slider that could kind of slide from one to the other, and you can have all sorts of things in the middle. For example, decisions made with your parents, maybe decisions made under strong pressure from your parents and clinicians and so on. And so you have different kinds of factors that feed in, like level of motivation, relationships with team, and competence or capacity. But actually, where you sit, what's the appropriate place to sit the slider, it might also depend on the severity of the illness, how old you are, and also what decision making style you prefer yourself in terms of your preferences and your culture and so on. I want to move on last. I think this is probably my final slide about Ulysses agreements, which is advanced decision making. I don't want this to be confused with advanced directives, which are about refusing treatment. This is a model of trying to positively make decisions in advance. So if you start with the green box, a patient's recovering from severe illness, they've maybe been hospitalized or something like that, they recover their decisional capacity and they recover their ability to reflect on experiences. At that point, you engage the patients and significant others in learning tools and strategies for relapse. Obviously, you do. But at the same time, I suggest that you reflect with them on what the warning signs of relapse are, for them to notice, for others to observe. Reflect with them about what the patient wishes to happen in the light of their past experience. What do they want done? When do they want it done? What worked last time? What's needed? And then hopefully agree with the patient, between the patient team and others, what threshold is needed for action, what action is needed, and what if they resist at that time because they may have lost capacity. And then sign and agree a plan, give them copies, and that they can waive at the emergency admission doctors and so on, and activate the plan if there's any relapse. So what we're trying to do is actually involve the patient while they have the decision making capacity, so as to actually guard against the time when they may not have the capacity and the eating disorders in the driving seat and they're fighting you. Oh, we do have a little bit more, sorry. Just to round up, good professional practice, honesty, really important. Understanding of limitations of the self and others, and be honest and seek help. Containing anxiety and risk, good communication. Reflexivity, which is the ability to reflect on your own processes. Good management, willingness to hand over to colleagues. If when it's always different strokes for different folks, and a willingness to get second opinion and consult with others. I'm going to end now. We've got last words. They should always come from our patients. What we found in the research, patients respect honesty. Patients need to trust us. It's all about the relationships. Patients appreciate support. They even appreciate leverage or compulsion if they experience it as respectful and caring. Patients can have difficulties in decision making or show degrees of consent, but they need us to be able to be flexible and responsive according to their needs. So we mustn't be black and white. Eating disorders are themselves too black and white, and we mustn't respond that way. We need dialogue, openness, and honesty with our patients about dilemmas. They appreciate that. Patients do want us to save their lives, but they want us to engage with them in struggling together against their illnesses. And don't forget the families. The families have needs too, and the patients also live in families and society. Two quotes to end. I knew that everything was going on when I was very ill. I was fully with it. They were treating me like I was about 10 and I was a vegetable because there were doctors phoning up, coming in and out, discussing things. I was just sat there waiting for hours doing nothing. And they wound me up so much. And they said I wasn't fitting well enough to go home looking at me. But it was because they were winding me up that I looked that bad. If they had done it more calmly, I don't know, it would have been better. And this person said, I think the treatment is really good, really appropriate for me anyway. I think they're quite good at getting the balance between giving you responsibility and freedom without giving you too much. And she laughed. Giving you more than you can cope with. Like they don't sort of, the freedom they give you doesn't jeopardize your recovery. It sort of makes it more bearable. I think that's a wonderful. So thank you.
Okay, so we've got about half an hour for questions, but firstly, I'd just like to thank Jacinta. That's been a really helpful presentation. It's a very pertinent issue for all of us working at the coalface with people, young people and adults with eating disorders. The ethical issues can be really tricky, but Jacinta's given us really useful concepts. So I'll take questions now. I think somebody's typing a question, and we've got just under half an hour for that. So I'm really interested in knowing how the concepts Jacinta's been talking about actually fit in your own day-to-day context. Um, so yeah, somebody is typing here, but if we could all think, are there particular issues that don't fit or that you're finding helpful? A couple of people typing. And while we're waiting for people to type, I just wanted to ask Jacinta myself, with regard to the research that you've talked about, what do you think really particularly influences your practice, having done research? What are the things that you've drawn into your practice, having learned from the patients?
I think the real privilege I had in sitting for hours with patients as a researcher taught me that to respect what patients really think. I think sometimes, I guess maybe, I'm a doctor. So I think we're not sometimes not very trained to try to really take the multi perspective view, and which I think it's quite hard to articulate because I think although therapies like family therapy do try to look at perspectives, there's still underlying it this general objective that we want to make people better, we want to do this, we want to do that. And I think sometimes patients really appreciate it when you just sit there and are just curious, without that kind of agenda. Because patients often, well, they don't often know, they always know when we have an agenda. And I think they really appreciate it when we say, no, I just want to hear you in that. I would say as a clinician, that's the thing I learned the most and the thing that I have found the most helpful that I take with me.
Okay, thank you, Jacinta. Now I've got a few questions here. First question is, do you find it helpful for the patient to switch treatment providers if palliative care is chosen? So how do you think that should be sort of organised if somebody says, yes, that's the route I want to go?
Yeah, I think, see, I would think that the best approach using palliative care is not about writing patients off and then handing them over to palliative care. I think palliative care should always be brought in to when it's used to actually help and advise us in how to actually orient towards looking at empowering patients, about revisiting goals, about really valuing their quality of life. And it, in an interesting way, I think it ties into what I just said about not having the agenda. I think the good thing about palliative care physicians is they're really good about not having an agenda, because they are even agnostic about whether you're going to live or die from it or whatever. They tend to leave that, say in cancer patients, they'll leave that to the cancer doctor, the oncologist, to manage. Do you need aggressive treatment? How aggressive do you need it? And all that. What they do is they then come alongside and they talk about all these other aspects of life. And I think that would be actually really quite helpful. Um, so I actually think that palliative care physicians do not have the expertise to completely manage our patients on their own, unless we are saying, do you know what, we're just going to all give up and pull out. And I'm not sure that's necessarily very helpful to people.
Okay, here's another question come through. Um, it's from a graduate student, research and ethics. And the question is, it's a very interesting and pertinent question. What are the particular areas that are important to study within this field? You know, what do we need to be doing next?
Uh, I want to have a discussion with you, Anne, about it, because I don't think it's something for me to dictate. I think, well, for instance, I don't really see much research out there on decision making in other eating disorders. That's worth looking at. But I think the trouble is, certainly in the UK, since I did my research, there's been a lot of capacity legislation. And what's happened is the capacity legislation is very, very cognitive. And I think we need to have we need to push back a little bit and actually think in much broader ways about how our patients need us to, engage with them, sometimes use leverage to help them in the fight against eating disorders. I think this very cut and dry, I'm forcing you or you're making all the decisions yourself kind of dichotomy has been very harmful, I think, to eating disorders because it just doesn't apply very well to our patient group. And that's all eating disorders. I think they really struggle with the functions of the eating disorders, how they hate it, but they hold on to it, all those kinds of issues, I think don't fit very well into all the capacity legislation.
And I think the qualitative work has really highlighted the patient's perspectives around that. And it maybe we need to understand a little bit clearly the whole process of treatment decision making and how that is for patients. Different styles, different strategies are used, and how that really is. But there's lots more room for research, and yeah, it'd be interesting to hear what other people feel in the group, whether they're working on issues, what other people's views and interests are. So we've still got about 15 minutes or so.
I've got another suggestion. We don't research enough our impact on our patients. We do a lot of research about our patients, but actually what comes out very clearly is we have a very powerful effect on our patients. And so when you talk about giving up hope, patients give up hope, they want to give up. I always wonder what interaction is going on between the treatment team and actually I have a real question about how as a clinician I continue to maintain hope when I'm frustrated, when and I think there's not enough research or theoretical work on the the power and the impact of teams. I think there's been quite critical sociological stuff about, the power of the health professional, but I think that's not very helpful. It's very much more about this kind of dance that we have with our patients.
I think that's right, because just in the same way that parents we know can have a profound effect on whether the eating disorder is maintained or whether it moves on. I think you're right, as treatment providers, we also have an impact too. Now I'm aware somebody else was trying to type a question or a comment just then. Not through yet, but somebody's still typing a comment. There's a little bit of a lag. And if other people have comments on this particular issue of what we want to research, what we need to research, or any other issues relating to Jacinta's talk, please type, because we've got a bit of time left. Here's a message coming up.
Oh, did you see my question?
No, I didn't see the question. Oh, right. Maybe there's another question. I'll scroll up. Maybe there's another question I've missed here. We've had the one about treatment providers. No, I don't think we addressed that.
Sorry, we didn't see that question, so can we have it again?
Yeah, please, could you type the question again, because for some reason, it didn't come through. Oh, here we are. The one about working in community mental health. I hope that's the one. So, yeah, so somebody has asked a question relating to, yeah, I'm just going to scroll back.
You read it out, maybe.
Yeah, here we are. I'm working in a community mental health, and I'm getting adolescent clients whose families are really ambivalent. Right, whose families are really low on resources, and the teams are ambivalent about treatment.
The teams are ambivalent.
Oh, the teams are ambivalent about treatment. So the question, I think, is about families who are low in resources and they can't really support their young person. The teams are ambivalent about treatment. Is it ethical to treat a patient who will engage on an outpatient basis but needs a higher level of care? Sometimes they can't get insurance to pay, and sometimes they don't want to go to a higher level of care. That's a really interesting question, and particularly pertinent for countries where actually there is private care. So, Jacinta, what do you think about that? So the question around the ethics of providing a care which perhaps you don't, maybe isn't the right intensity.
I'm sure you do, because you're the adolescent psychiatrist. I think we have our duty to do our best for our patients, and sometimes our best is what we would consider not good enough, but it's still our best, the best that we can offer in the given circumstances. And I know that happens all the time in a whole lot of circumstances, even in the UK actually, that often you just don't have what you know the person needs, in which case I would say whatever you can give is probably better than nothing, But I suppose I'm sort of thinking there's several different ethical issues, because say at outpatient you could practically do something as a day patient if you see them very often, if they come and have meals where you are, and creatively you could do quite a few things. But I think there's a slightly different ethical legal thing where you might have to be careful to be stating throughout that you think they need a higher level of care, because there's a slight risk that you then might be accused of treating someone with suboptimal care. And I think you then need to be saying, I would give them more, but given the circumstances, they won't. I can't. And so it's sort of, in my view, it's sort of doing the best of a bad job, and giving the best you can in the circumstances, which I'm sure is a great deal better than nothing. So it's one of those kinds of things, and it's a terrible bind when patients aren't able to afford, or indeed their parents can't for various reasons give them what they need, and we see that all the time and struggle on with it.
I mean, I suppose there's something too about the way outpatient care is organised. So outpatient care can mean a lot of different things, depending on your context. But outpatient care could potentially involve home treatment, which it does in some providers, or a greater intensity than weekly appointments. So I suppose that there is a question of actually working out within your own services actually what outpatient care can potentially mean, and trying to be creative with different ways of providing outpatient care. because certainly for teens, there is very good evidence that family-based work can be effective for anorexia, for example. Um, but if it's in effect, if it has minimal effect, then actually looking at a greater intensity of treatment may be the next step.
Yes.
But it's about really thinking carefully about what is the sort of outpatient care that's provided, and in a sense there are ethical issues for services about how services are organised. I don't know if that answers your question, but do come back if you want to make a comment about that. We're getting another comment here. But it is a tricky issue where there's private treatment and perhaps families can't pay or that there aren't resources. So we're getting a comment coming through here, and if anybody wants to comment on this particular issue or any other issues, please type a question, because we do have 5 to 10 minutes. So there's a comment here just coming through. Oh yeah. I think somebody has typed a question saying, "Did you see my question above?" But I'm not sure if there's another question. I'm just scrolling through to see if there are any more questions. Does anyone feel that I've missed a question? Yeah.
Oh
yes, here we are. New question has come up. Yeah, there's always a bit of a lag. Sorry about that. Right, the question is, I've decided that I can't treat if they won't see a nutritionist and doctor at least. I mean, that's a really interesting question actually about if the patient says, right, I only want this particular part of the treatment, I don't want medical assessment or I don't want nutritional assessment. So Jacinta, what do you think about that?
Wow, that gets really difficult because, I mean, obviously it's one thing. I think that there's several different kinds of issues. So one is obviously if the family can't pay and they can't go to a higher level of treatment, but they are on board. And then of course, then it's about how creative you can get, how intensive you can get. But I think if they try to cherry pick, which is very common, I think, and actually say they want this kind of treatment but they won't accept that element, I think then sometimes there is room for saying, do you know what, this is the whole package, because you will not get better if you won't deal with it. And sometimes I think if we accept too much cherry picking, the classic one is, I want the psychological therapy but I don't want to gain weight, then or they try and put you in a bind, like, I will see you but I won't see the doctor and I don't care if I collapse on the street. Then they put you in a terrible bind. Then I think it's perfectly ethical to say, no, you know what, this is not a safe way of practicing, and we can't give you proper treatment, because I think sometimes it could wind up being colluding with a patient if they're trying to kind of I think I used the word self-sabotage before, and I think there can sometimes be this, yes, I want the treatment, but I'm going to sabotage it as much as I can by trying to sort of dictate exactly how it is. So I do not think, whenever I talk about patients' views and their choices and all that, I do not think that is the same as letting patients push us around so that they actually negate the effect of their own treatment, or so that they actually make practice unsafe, which then puts you in a terrible, position ethically and legally.
And there's something too about the stage of treatment. because it's interesting talking to patients at the end of treatment, and also what came out of the research that Jacinta talked about, that patients often say when they come at the start of treatment, they don't make decisions, and they actually want to be told what to do, or they want to be given the boundaries. So actually, autonomy is not such an important issue right at the start. It's safety and risk, medical risk. But as treatment goes on, autonomy obviously becomes much more important. So it's a process of, at the start, if there's medical risk, then you can't necessarily actually allow for autonomy at that stage, and it might be that the patient has to be looked after and made safe. So I think we've just got, we've got about 5 minutes, maybe time for one more question. I don't know if that answers your question. If you want to come back on that, do. But we've got time for another comment or question. I just want, I think somebody is typing actually. So okay. I think, somebody's just said thank you very much. So I think we're just about at the end,
yes,
really. But I just want to say thank you very much. We put Jacinta's put the references up, and I want to thank Jacinta very much for a fantastic talk, because it's really highlighted a lot of very difficult concepts, and I think she's given us some useful tools to think about. So the slides will be available. You'll get a link so that you can see the slides, and you can look at the podcast again. So we're just about at the end, but I just want to remind people that the next webinar is scheduled for February the 15th this year, so next month, at 8 p.m. Eastern Standard Time, with Ruth Striegel-Weissman, PhD, who's going to be sharing tips and information on how to publish in the International Journal of Eating Disorder if English is not your first language. So you can find out more about this and other upcoming webinars by visiting the aedweb.org and clicking on the events tab. So thank you very much for everyone that participated.
Everybody. Yes.
And have a good rest of your day or your evening.